Good afternoon. Thank you so much for attending today's Navigator Network meeting. This is our last meeting of the 2025 year in our fourth quarter meeting. My name is Macy McFarland, and I am the program manager for the Screening Saves Lives program. A quick look at our agenda for the day. We will go through network updates and navigator input. We will hear from Chad Dingman from Gibbs Cancer Center on the Gibbs Cancer Center tobacco cessation program. And then we will hear from Stacy Thiedeman from WakeMed on WakeMed's Quit with WakeMed tobacco cessation program. After, we will have a Q&A session for anyone with questions, and then we will close and discuss next steps for the next year.
We want to say a huge thank you to our sponsors, Amgen, Merck, Lilly, and Johnson & Johnson for their support of the Lung Screening Saves Lives program, along with the Lung Screening Navigator Network. We could not do this work without their support.
To better support your screening programs and you as a navigator, we would like to keep our information of our navigator contacts up to date. Please complete this brief form. This will allow us to accurately share and promote your program to individuals seeking lung cancer screening. As a thank you, everyone who completes the form by December 19th will be entered to win one of two $25 Amazon gift cards.
With that, I do want to open the floor for anyone to share any highlights, challenges, or announcements that you've experienced since our last meeting in September. Since then, National Lung Screening Day did take place on November 8th. So if anyone has any wins from that day or any highlights that they would like to talk about, that's just an idea. Feel free to drop those in the chat or come off mute. To get the ball rolling, I will share that I was able to attend Novant Health's National Lung Screening event on Friday the 7th. They also hosted an event on the 8th and provided information about the Lung Cancer Initiative, provided some goodies, and I got to work with their navigators, Denise and Morgan, and it was phenomenal. They did a wonderful job, provided snacks for their screening patients, and got them through just seamlessly. And it was a wonderful time to get to partner together for that. With that being said, I am pleased to introduce Chad Dingman. He is the Director of Oncology Support Services and Centers for Integrative Medicine at the Gibbs Cancer Center, and he's going to be speaking on their lung screening program.
And Macy and Jenny, thanks so much for this wonderful platform for us to collaborate and share. I think there's a lot of wonderful ideas and programs out there, so it's good to always jump on these calls, hear what other people are doing. And so I'm just going to share a little bit about our smoking cessation journey. As far as the community cancer center, for those in the North Carolina area that might not know too much about Spartanburg or Gibbs, this is kind of who we are. We are located in the upstate of South Carolina. We have 4 locations. Spartanburg County have a hospital in Cherokee County that has a cancer center. We have an outpatient newer hospital in Union County that has a cancer arm there. And then the building that you're looking at on the screen is our newest 2020 cancer center that is in Pelham, which is sits right on the Greenville-Spartanburg County line by GSP Airport. And so as many people on this call probably experienced, when I first came into oncology in 2003, we had one center in Spartanburg. And so I think our journey with smoking cessation is much like our journey with screening and other initiatives in the lung space is how do you do adequate patient care and good cancer screening when you have many, many satellite buildings, when your campus is growing from 1 location to 4 locations. And so we'll share a little bit about that through this presentation, but we see about 3,600 analytic cancer cases, and lung cancer screening previously lived with radiology. And then I took it on in 2018, have a wonderful team. I'd be remiss if I didn't mention Tara Morris, who's on this call, and some of you may know Tara. Tara came to me in 2018 and was the lung program, and since then we've grown. Jill Casey is our incidental lung screening navigator, and Kara Grant is our lung screening navigator. So our team is growing. I think one of the unique aspects for us is previously, and I'll date this back to probably 2010, 2011, we had an opt-in smoking cessation program. So essentially, we had a part-time nurse who was trained in a Quit Smart initiative, and she would see patients individually in the clinic. And so if a patient came in for cancer treatment, was seeing the physician and wanted information, there would be a discussion between the provider and the patient. If your situation was anything like ours, folks going through cancer treatment, they weren't really interested in stopping smoking. They had a lot of other things that were going on. They were more interested in getting to treatment. A lot of them had anxiety. And so tobacco use was something that helped reduce that. So they weren't in any space to want to quit. So I don't think we really had high volumes in that opt-in program. And so we weren't able to sustain the resource. It was very financially intensive to pay a TTS nurse to do one-on-one services. So in 2022, the SC Can Quit initiative was rolling out a grant program to look at shifting from an opt-in program to an opt-out program. Best way I can describe that is opt-in is fishing with a pole, opt-out is fishing with a net. So you're not asking somebody if they want to do this. You as a program are invested in people's health, and stopping smoking is something that you believe in. So everybody who's an identified smoker that comes into the Gibbs Cancer Center as a patient is enrolled in the program until they opt out of the program and tell us they don't want to be in that. And so I'll share the data and why that's been valuable for us in a second. But we partnered with a third-party vendor called TELAS Quit Manager. They're out of Canada. Also have an office in South Carolina and in Seattle. But they interface with our EMR, which we're Epic, to automate the follow-up of identified tobacco users in specific departments. So one of the unique things is through enrolling this in an Epic platform is you can be department specific with where you roll out a smoking cessation initiative. So right now in our center, we do all of our low-dose CT patients, all of our Gibbs Cancer Center patients, and then we've moved it into the primary care space. So I have 2 primary care offices that we're piloting to move cessation services into those areas. We know in 2025 that people communicate in many different ways. And so this particular platform consists of interactive voice response phone calls, emails, and also text messages. And so the IVR calls can be customized. And so, again, phone etiquette and behavior in 2025 is kind of interesting. I think people see a call come in, they'll look at where it's coming from. They don't recognize the number. They may let it roll to voicemail, and then they immediately call that number back. And so we're aware of this. And so I think it's taking time and being very diligent and how you communicate with patients that you're opting, have an opt-out program for, how you're communicating with them to let them know who you are and why you're calling. There's an algorithm that has been created through TELASK, and patients receive communications at certain intervals. We know people need many opportunities to receive the message of there are resources to help you stop smoking. We know it can't not be a one and done. And so this particular program calls people on day 3 until there's an answer. Somebody opts out or decides to ask for services with the intention of connecting them to our South Carolina Quit line. And so at these day intervals, our patients are contacted with the goal of connecting them to Quit line services. And then our TELASK vendor provides some very good data for us to look at, to track volumes, to track demographics, to track statistics. And so in our, this is actually my screen in Epic, took a screenshot. And so you can see there is a Quit Manager option at the very, very top of our Epic platform. And so this is the space where our team goes in and manages kind of the people who are plugged in automatically through that algorithm, because when they come into any of those locations I shared with you, and they're an identified smoker, they're automatically enrolled in that program. And so they will receive a phone call. So if I was an identified smoker who went to Gibbs Cancer Center to see my physician on a Monday, on Thursday, I'm going to start to receive the phone calls, the text messages, the emails of trying to connect me to the South Carolina Quit line. So this is a sample. Again, it's all kept in this very nice, concise space in Epic. So this is kind of my Quit Manager log. You see the very top line there, you see patients from June. And so we do a follow-up call at the 6-month interval to check to see if people have been successful smoking, if they have quit and relapsed and want to be reconnected. And so when somebody has, as this particular person on the very top line, on their day 3 call had asked for connection to the helpline, we will not call them anymore because they've had a call to action. We will wait for the 6-month part and then follow back up to them to see what their disposition is and if they need to be reconnected or if they've been successful with stopping smoking. And so I love that there's drill down capabilities inside of this platform that allows me. And so if you remember from the previous screen that the very top patient who on day 3 said that they wanted to be connected to services, this is actually the telephone call and how they answered the interactive voice response questions. And so this person on day 3 was reached, and you see the questions there kind of in the middle of the screen. Am I speaking to? And they, press 1 for yes, 2 for no. And it goes through that they're an identified smoker. Is that correct? When is the last time that they had tobacco? In the past 30 days, have they tried to quit? Would they like help quitting? Would they like to be transferred? And so there's a warm transfer element to this platform, as well as if you have somebody on the phone who is wanting to be connected, there's an element for them to be transferred directly and talk to a coach at the Quit line. And so this is very helpful if you have providers who are working with patients and there's a discussion about, oh, I didn't receive the phone calls or no one's reached out to me. This is a kind of an accountability piece that we can actually tell the day and time and the answers to questions that people have received. So this is kind of, I think, the proof in the pudding for us as a center that is not incredibly blessed with a ton of resources, but we look at a situation to where how can we reach the most amount of people with the goal of connecting them to resources that can help them stop smoking and do it in a way that's less resource intensive. And so if you look at this particular slide, you're looking at those day 3 data element of the people. And this is just for Gibbs Cancer Center. And so since we rolled out the program in late 2022, we've reached nearly 3,000 patients through Gibbs Cancer Center with 907 referrals to the South Carolina Quit line. And so our previous process and structure, there was no way a part-time nurse could see that many patients and connect them to resources. And so this has been a very less resource intensive way to connect to a lot of people with the same goal of providing them opportunities to stop smoking. And you can see a breakdown of kind of how people receive information. And so a lot of people do respond to the automated calls, but also people do answer text messages and do sign up through emails. And so all of this data is provided to us monthly, annually, however you want it. And so this is our low-dose CT program. And you can see kind of similar numbers, similar results over that same. We went to about 6 months after we rolled out Gibbs, we rolled out low-dose CT. So about 2.5 years into the process, we reached almost 2,500 patients through this platform. And again, you kind of see the data there, 37% of those on the day 3 mark, almost 1,000 patients were referred and asked to be connected to services. So again, very large numbers of patients in that population, and easy ways to connect them to the South Carolina Quit Line. And this is our consolidated. And so if you look at all of our platforms, so our Gibbs Cancer Center Clinic, our Low-Dose CT program, our 2 primary care physician spaces, and then most recently we moved it into our charity care program. So those folks that do not have medical insurance or do not have medical homes, they now, if they're identified smokers, have an opportunity to connect. And you see over 13,000 eligible patients in that time frame, with us reaching about 8,400 and a little greater than 2,700 patients referred to the South Carolina Quit Line. And so consider that very successful of what we've been able to accomplish with minimal FTE resources. And so it's very nice that these algorithms happen behind the scene. It's built into Epic. And we just are there to kind of manage and answer questions. This is an example of a monthly report. And so again, the data for each department can be drilled down to age, sex, race, insurance status. It'll tell you how many patients qualified, how many patients signed up. And so very friendly data feed from our partners at TELAS that is helpful to share with our Cancer Care Committee. For those of you who serve on Commission on Cancer accreditation, smoking cessation is a new standard. And so having programs that are already pre-built in that allow you to be successful will now be something that will be a standard of Commission on Cancer surveys. So I like that we've already kind of been hard at work at this, but I think programs like TELAS make it very easy to build infrastructure and programs to be successful with that new standard. And this is probably the most important one. Lessons learned. Again, this was a new venture for us, and so administrative and physician champions are a must. What we found is the most successful program is one where physicians are having dialogue with patients that are supporting your program. And so at Gibbs, our physicians, when they're meeting with patients and know they're identified smokers, are basically having a 2-sentence conversation of, you're going to be receiving a phone call in 3 days to help connect you to resources to stop smoking. Please answer that call. And so when we can engage our physicians to have these conversations with our patients, I think it removes some of the stigma, removes some of the shame of, we want to help you. It's not a, are you smoking and you need to stop? It's a, we want to help you be successful for your health. You're going to be receiving a phone call to give you opportunity to connect. And then the provider communication with patients is giving them an elevator speech, giving them 20 to 30 seconds to say, hey, this is a soft way that you can have a difficult conversation in the clinic to help people connect. We have struggled with this, and I'm sure other institutions have as well, of, for whatever reason, it can be very difficult to get accurate and updated smoking history. If it's not in the patient's chart, none of this downstream stuff can be successful. And so if they're a smoker, but somebody has not put them in the system as such, it's not going to trigger any of these wonderful interventions that we have for this patient population. And so making sure you're working with office staff, working with MAs, working with nurses and PARs to ensure that every patient who comes in is getting an accurate and updated smoking history in the medical record. I think a relationship with the state-sponsored quit line is important. I've developed a relationship with Katie Wynn in South Carolina's SC quit line because we're sending a large volume of patients there. We're really looking at trying to get better data back from them about success rates. How many people that we're sending from Gibbs and our primary care physician offices and our low-dose CT program are actually quitting. And so we haven't been able to capture that data yet, but working with the key players at the quit line, I think can be essential for um, appropriate and adequate outcomes and then success of your program. I think what we've also learned is a specific and concise voicemail about what the call is about and why they're receiving it. And so, as I said, phone etiquette, a lot of people will look and see when we reach out through our interactive voice phone call system, it actually says Gibbs Cancer Center on it. And so we want them to know it's coming from us so that they're more apt to answer the phone. And then when they get to the voicemail, it's very clear of why they received the phone call. There's also information about connecting to the South Carolina Quit line. There's the phone number, and there is, if you have questions, um, please leave a message and we will call you back. That's important, is having somebody who can kind of man the voicemail line to call patients back to answer questions. I thought when we first rolled out, we would get a lot of calls of people who would say, you know, you're bugging me, you're calling me a lot, please stop, take me off the list. And while we do get those, it's more patients who say, I really want to stop. I missed your call. Can you call me back? And so I've been kind of surprised to see the engagement of folks who leave a voicemail that want to receive services or be connected. As I mentioned before, minimal staffing for us. And so Kara and Jill from my team work the security feature, allowing data to transfer back and forth to Epic, which is a simple click in our Tell Ask Quit Manager platform. And then answering, I would say, anywhere from 10 to 15 voicemails a week that we get through our program. And so very minimal staffing that's required. And then lastly, the piece that we're kind of working on now is how do you bring tobacco treatment specialists into work one-on-one for greater engagement with patients. And so I think we still know and believe that sitting down, developing a quit plan face-to-face is probably the most successful way to go about cessation. There's billable codes. We've talked to some people. I've sent many people from my staff to be TTS trained. And so I think that's our next venture is, how do we work with meeting our patients in the clinic who are interested in stopping and being successful in sitting down with them and developing a plan. So, all right, that's it. In respect to time, I'll throw my contact information in the chat. That way, if you do have questions, please reach out to me. I want to be respectful. I think, again, just in closing, this is if your center is anything like ours and continuing to experience that population growth, having multiple satellite campuses where you just can't put physical people to do one-on-one work, this may be an opportunity or an option for engaging and reaching many people in different spaces, and also addressing the new COC standard for smoking cessation services that do not take a ton of FTE resources. So thanks for your time. Thanks for letting us share a little bit about our program. And again, would be more than happy to have a one-off conversation over the phone or through email of anyone who might be interested. I can kind of share the good and the bad of developing EHR-based programs.
Chad, thank you so much. Even just from our, previous conversations, I've just been so impressed by the program's innovation and ability to really use collaboration and partnerships to just multiply success. So thank you so much. And if you're available to stay on for a Q&A, that would be wonderful. With that said, I will turn it over to Stacy Thiedeman. She's a physician's assistant with WakeMed over the tobacco cessation program called Quit with WakeMed. Stacy, I will hand it over to you.
Great. So thank you so much for having me. I'm a physician assistant. I've been at WakeMed since 2001 and worked in pulmonary and cardiology, and started the tobacco cessation program with the system almost 6 years ago. So I'm excited to tell you about our journey. And I'm also excited to specifically to talk with this group because I believe you all have a great opportunity to help tobacco users. And you are talking with patients at a time when they might be very motivated to work on cessation. And so your ability to provide them with resources or dispel myths about tobacco cessation is really important. I had a patient that I worked with a couple of years ago who had a history of coronary disease. He'd had a heart attack. He had peripheral vascular disease that was very debilitating for him. And we started medication and we worked on cessation. And he really cut down, but he couldn't get rid of those last few cigarettes until he had a CT lung cancer screening that showed a nodule. And so that was the key to help him quit for good. And so again, I think the lung cancer screening work is so important, and it provides us all with lots of opportunities to reach patients and help them have better health and better outcomes. So my objectives are to tell you a little bit about our program's origin and our model and how we've worked to make it sustainable for our system. I also want to talk to you about the nature of nicotine addiction and therapies. We work with smokers, people who vape, people who smokeless tobacco. So it's any kind of nicotine addiction that we are dealing with in our WakeMed program. And then I just also wanted to give you some resources and clinical pearls. So hopefully I'll be a nice complement to all the great information that Chad shared about getting a program up and running. At WakeMed, we start with our pyramid where our patient is at the top, and there are lots of things in this pyramid that I think relate to tobacco cessation and the importance of having a program. But I particularly think of our aspirational goal for healthy community. So we want to be a leader in making Wake County the healthiest county in the United States. And when I talk to patients, I say, if you want to do one thing for your health, quit using tobacco, right? It's at the top of the list for making impact for health. Just some statistics. 19% of the people in the U.S. use some sort of tobacco. Smoking kills almost 500,000 Americans every year. It costs our country a great deal of money in our health systems. A lot of money. And of course, lung cancer is a condition that where smoking is the greatest risk factor, and it's the leading cause of cancer death in the U.S. So, again, lots of reasons to address tobacco for our patients. So, what we know about tobacco cessation programs is this, or attempts to quit tobacco. Self-directed quit attempts with no provider, no resources work about 3 to 5% of the time. So that's very low. So patients will come to me and say, "Oh, I've tried to quit many times. I know somebody that just stopped, just quit." And I'd like to tell them, well, that works about 3 to 5% of the time. And so they were very fortunate that method worked for them. With provider advice and treatment, a primary care physician, a pulmonary specialist, the average quit rate is about 10%. Quit lines are slightly higher. Some quit lines have higher success rates than others, for sure. But we know that specialized treatment for tobacco dependence works best. So somebody who's an expert in therapies and behavioral tools with regular follow-up, that's the best situation for creating high quit rates. It improves outcomes, comprehensive evaluations, when I see a patient, I am talking to them about their tobacco history from the time they started to present. Most people have tried to quit multiple times, so I'm asking, what things they've tried in the past, what's worked, what hasn't, what side effects they've run into. Uh, Contemporary pharmacotherapy, so medications double the chance for cessation success, and I'm a big proponent for using medications when they're appropriate and accessible. Behavioral treatment is has been shown to be critical to working on tobacco cessation, and then long-term follow-up. So when we see patients at WakeMed, we're scheduling follow-ups, and I tell patients, if something's not working, if things aren't going well, we're going to change our plan, right? And so that's where I think um, tobacco cessation plans fail at the provider level, because patients may get a medication, a great medication, but if something happens with it, if there's a side effect, if there's an adverse event, then that opportunity is lost. So so we keep working and we tweak our plan, and it takes some long-term follow-up to really be successful. So how have we created a sustainable model? We utilize physician assistants and nurse practitioners. There are two of us. I'm a PA. My colleague is an NP. To do virtual visits with patients for tobacco cessation. We bill insurance for our services. We bill based on time, and that has helped us keep moving forward with our program. We have a behavioral health specialist at WakeMed, a tobacco treatment specialist in our virtual behavioral health program, who we can refer to for more intensive behavioral tools for cessation, and they bill for their services. And then we generate revenue for our system by our referrals. So we assess eligibility for lung cancer screening and order that testing as appropriate. If I have a patient who doesn't have a primary care provider but needs one, I'll refer them to our WakeMed primary care. I've referred patients to cardiology, to pulmonary medicine, to all sorts of places. And I've ordered PFTs at times because patients want to know where they stand. They're short of breath, and that's a good thing to get started. And as a prior pulmonary PA, I have the knowledge to help interpret those and explain them. So we order some pulmonary function testing for patients as needed. So this is just a diagram of how our program works. We are receiving referrals based on presentations made mostly to our own providers, right? To WakeMed Primary Care, to WakeMed Specialty Groups. We advertise. We have BPAs in Epic. If you have Epic, you get these alerts that say, "Hey, your patient's a smoker. Do you want to refer them to tobacco cessation?" And we have lots of resources in our offices regarding our tobacco cessation program, and patients will often request it. I can't tell you how many times a patient has told me that they heard about our program because they saw our poster in their primary care provider's office, and asked, "Hey, what's this about? Can I have a referral?" Patients don't have to have a referral to see us. We determine when we hear from a patient if they need one and help them get one if they want to see us, but oftentimes patients can self-schedule with us. We receive referrals from our inpatients. So we have a process for our inpatient population where if say somebody's admitted for pneumonia and their pulmonologist wants to engage tobacco cessation, um, they can be connected with us and outpatient appointments can be arranged. Um, we again refer to our outpatient virtual behavioral health team. We make other referrals, and then most importantly for this situation, and probably the most important thing that we do outside of our work on tobacco cessation is helping folks identify their eligibility for lung cancer screening. So we're asking every patient we see about PAC year history so that we can talk to them about their eligibility for screening, and we're documenting decision making in our visit notes. Often we'll order the studies ourselves and follow up on the results, and we're making referrals to our pulmonary Lung Screening Navigator so that follow up on these cases is ensured, and appropriate referrals are made if lung cancer screening studies are abnormal. So I wanted to talk to you all a little bit about nicotine addiction, hoping that when you're speaking with patients, if they make comments, you can dispel some myths. So nicotine is at the top of the list in terms of addictive potential in substances. It's right up there with heroin. And in smokers, it crosses from the lungs into the blood and then into the brain very easily. So when somebody smokes, the area of their lungs, if you spread it all out, is about the size of a tennis court. So they take in nicotine very quickly, hits their brain within seconds, and reaches maximum concentration within minutes. Chewing tobacco is a little slower. It's going through the oral mucosa and reaching maximum concentration in about 30 minutes. And what nicotine does is it stimulates acetylcholine receptors in the brain. And what happens with that stimulation is the subsequent release of very good feeling neurotransmitters. So it stimulates the release of dopamine, which plays a key role in reward and pleasure and makes us feel happy. It increases serotonin, which is involved in emotion regulation, makes us feel calm, and it increases norepinephrine, which increases attention and motivation. So it feels good to smoke, and that's what we're up against. So when somebody tries to quit smoking, it's hard, it's tough. Nicotine leaves the system completely after about 3 days, and then we see withdrawal. We often see withdrawal, and that can, involve irritability, anxiety, depression, headaches, difficulty sleeping, GI upset, all sorts of things. And so that's what takes people back to smoking or tobacco use when they're trying to quit. And over weeks to months, things get better and the brain figures out how to function without nicotine, but it takes some time, and that's why our medical therapies are really important for managing withdrawal, and that's why they really help increase success rates. So we don't have a ton of medicines for nicotine dependence, but we have kind of our main three, which include Chantix or varenicline, nicotine replacement therapy, which encompasses patches, lozenges, gum, and nasal spray, and then Wellbutrin, which is an antidepressant, or bupropion, or years ago it was marketed as Zyban for a smoking cessation drug. So I just want you all to have a little bit of knowledge about these drugs in case a patient says something to you. What Chantix does is it binds to nicotine receptors, so that when patients smoke, they don't get the same experience. They don't get the dopamine or the serotonin. It doesn't feel as good to smoke, and it really helps them put cigarettes down. It's associated with some side effects, and it has to be given with appropriate instructions. It's been expensive in the past, but the cost has really come down, and many patients are good candidates for Chantix, and it's the most effective thing that we have for tobacco cessation. Nicotine replacement therapy, of course, is very important in our work, and that's usually combination therapy with a patch and something short acting. It's very safe. It can be used while somebody continues to use tobacco, even though the insert says otherwise. There have been many studies about using nicotine replacement as someone is cutting down on their tobacco use, and I think that's the best approach. Well, Wellbutrin, like I said, is an antidepressant. It increases dopamine and norepinephrine, so it mimics nicotine. It's very inexpensive. It's a good choice for patients with mild depression, or patients concerned with post-quit weight gain. There is a lot of mental health. There are a lot of mental health disorders associated with tobacco use. Many people use tobacco to treat anxiety or depression. So Wellbutrin can be very helpful and kind of a double bang for your buck, helping with depression, helping with anxiety, but also helping with tobacco cessation. And about the medications, I will say you may run into patients who say, "Well, I've tried all those things, right? I've used all those things." Sometimes combination therapy is what we really need to be successful, and so having a provider with a lot of experience using these drugs can be very helpful. But again, behavioral tools for cessation are extremely important. So I wanted to give you all some resources today. For me, when I see patients, cost is a big barrier for what we choose to help them with their journey. And there are a couple of things that we use a lot for self-pay patients. I will say many insurance companies are covering nicotine replacement with a prescription. Chantix, Wellbutrin's not an expensive drug, as I said, but it's also well covered. But for self-pay patients or Medicare patients who don't have prescription coverage for tobacco cessation meds, these are good resources. GoodRx is a great one. So when I see a patient and we're going to use GoodRx, I send in a prescription and I send the patient a text with a coupon for buying nicotine replacement. Cost Plus Drugs is a great way to get Chantix for very little money. Chantix used to be $300, $400, $500 a month for patients, but at Cost Plus Drugs right now a starter pack is $15 plus a $5 shipping fee. So it of course requires a prescription, but it's a great resource for patients who are concerned about cost. We use our at WakeMed we use our North Carolina Quit line, and it's a fantastic way to get patients some free nicotine replacement to get started. I often find that they need it for longer than the Quit line can provide, but it's a very good way to see how they tolerate it and if it's helpful for them. And then programs like Quit with WakeMed are great to know about. We are 100% virtual visits, so anybody who's in North Carolina can see us. It doesn't have to be somebody who lives in Raleigh. I know that Duke has a very similar program to ours. They also have virtual options. Medical licensure requires that we see patients in our state. So if I'm licensed in North Carolina, I can't see somebody who's in South Carolina at the time of their visit. But I think being able to connect patients with programs if your system doesn't have one is of great value. So that's it for me. Thank you so much for your time. Like Chad, I am happy to speak with any of you offline and to tell you more or answer any questions that you have. I really appreciate your time.
Stacy, thank you so much for speaking to just your incredibly robust evidence-based program. And I just knew that you would be such a great person to speak on this topic. So thank you so much. I would love to get the ball rolling with a question, kind of for both you and Chad, and then we can open it up to the floor. And then I will open up for other questions as well. Feel free to unmute or drop in the chat. But I would love to hear your perspective on how we can address stigma while also increasing the number of North Carolinians that are being screened and South Carolinians that are being screened while not contributing to the stigma of smoking or tobacco use.
Hey, Macy, it's Chad. That's nothing like starting out with a real easy question there. I think that's the struggle, right? This is the walking on eggshells part. And so I always try, I think we at Gibbs, is there a positive spin that you can put on somebody who's coming in that is an identified smoker, whether it's for screening or cessation, um, and have the message be one of concern, not one of you need to do this. And I think that what I've noticed in my work in the clinic through the years is I think a lot of people feel that are smokers that they're going to be told that they need to stop doing something that they've done for a long time. And so how can we maybe change the way we deliver the message from you need to stop doing this to how can we help you? How can we be partners? How can we collaborate to help you be successful with something that's been very difficult? And so that in and of itself is a huge challenge. But when we're looking at the importance of screening and how successful and beneficial it's been, and I even just think, like Stacy talked about, is and the whole platform of this group is figuring out ways to communicate with the public about people taking care of themselves, people stepping into this space of there's a way that I can find out if I have early stage lung cancer. And so how do we celebrate that? I think that's the word I keep coming back to is instead of making it this shameful behavior is how do we celebrate you taking steps for your health? And if we can come from that stance and share that message with people, I think we might be more successful than we have been in the past of you're a smoker, you need to stop.
Yeah, I would echo that. I really think that when I present lung cancer screening to a patient, I say, hey, has anybody talked to you about your eligibility for this? This is like a colonoscopy. This is like a mammogram. This is like a skin, a skin check. That this, and it, you're a smoker. You have eligibility for this study to take a look at your lungs. I also say we get a lot of information about you beyond just looking for a lung nodule. I can see, do you have early emphysema? Do you have coronary artery calcification? We can get a lot of information on your health. And isn't that exciting? And shouldn't we do that, right?
Thank y'all both so much for that input. And I think those are really awesome, tangible tips that we can take to working with the public and educating and empowering individuals to take ownership of their health through lung screening or tobacco cessation. Does anyone have any last questions? Okay. With that, we will move into our closing for the 2026 year. These are the dates. We will meet on March 12th from 12 to 1, June 12th, and June 12th will be our in-person meeting in the Raleigh area. We will let you know as soon as a specific location has been decided on, but we do have registration open, and I will include those links in the follow-up email. We will meet September 10th and December 10th. I will send the meeting recording as well as all information in that follow-up email. Please remember to complete the Google form if you have not done so yet. Again, that will be in the email as well. Thank you both, Chad and Stacy, for your incredible information and expertise and knowledge sharing. And thank you all for joining and participating today.